thank you, Effie, for asking me here to talk to you today. And I think, first of all, I just need to acknowledge that I agree with everything Simon says, which should cut down most of my talk today. I think he's dismissed most of it. But what I've been asked to talk is about the use of CT in non-traumatic acute abdominal pain in children. So the learning objectives are as on this slide. I want to tell you about some of the advantages of CT in this circumstance, and then really to look at clinical scenarios where I would consider CT is useful for evaluating the acute abdomen in children. And finally, to talk about when we use CT as an adjunct to ultrasound in children with acute abdominal pain. Most of these in this table, it's a big, busy table, but Simon's dealt with most of them. And just to emphasise that the causes of acute abdominal pain in children are largely age-dependent. And generally speaking, they can be split into what we term medical causes and surgical causes. And a lot of textbooks would say that children with medical causes of acute abdominal pain tend to vomit first and get pain later. And conversely, children with surgical causes of abdominal pain tend to get their pain first and then vomit later. And as Simon so rightly said, many of the things that I've listed on this table certainly don't need CT. In fact, lots of the causes of acute abdominal pain in children don't really need any imaging investigations at all. And if we do image them, we would certainly start with plain radiographs and then, depending upon the scenario, perhaps need contrast studies or ultrasound and not CT. So what are the advantages of CT? Listed on this slide, and you can read through them for yourself, but important things as mentioned by Effie. So fat and bile gas are the enemies of the sonographer. And similarly, a lack of experience of a sonographer can certainly limit its use in children with acute abdominal pain, particularly when the sonographer has spent most of their time scanning adults and isn't used to looking at children. What is important is that when a child has acute abdominal pain, that we find out the cause of that pain quickly and we diagnose it accurately. The two pictures you see here on this slide are from a recent case. This was a 15-year-old boy with a 5-day history of abdominal pain and vomiting who turned up at the emergency department moribund. This is his post-mortem exam. You can see the pus leaking from the abdominal cavity, and this is an example with the liver retracted showing peritonitis. So even in this day and age, children die of perforated appendix because that was what was found at post-mortem. So when a child has abdominal pain, we need to find out what's going on. Disadvantages are radiation, radiation, and radiation. The case here, this is radiation burns in a 2-year-old boy. Admittedly, it's not his abdomen. It's on the web, so the parents have given permission for this image to be released. This is the Raven Knickerbocker case that came from California. This was a child who had 150 CT exams of his cervical spine over a 2-hour period. For something that in the UK he wouldn't have had a CT for anyway, and he got radiation burns. So please, if you do CT, I would stress to use the ALARA principle as low as is reasonably achievable, and to follow the Imaging Gently campaign that they advise. And certainly please call upon your medical physics department and your local paediatric radiologist to help you set up any of your CT protocols. But let's get real now. I'm a paediatric radiologist. I work in a children's hospital. I have a children's emergency department. I have paediatricians and I have paediatric surgeons. But the vast majority of children don't come to my hospital, even within the small province of Northern Ireland. They're going to go to their local hospital, where they're going to be assessed by people more used to adults in the emergency department. You might have paediatricians, but you're probably not going to have paediatric surgeons. And how much paediatric experience the radiology department staff have is going to be variable. In the UK, it is said in our curriculum that trainees should master paediatric abdominal ultrasound within the first 3 years of their training, and that they need to maintain that competency throughout their careers, but we all know that they don't. And so that is a problem. And of course, MR, still certainly within the UK, might not be available 24/7, and so it's only just been available in my own hospital within the last month 24/7. And there is still that adage that patients with abdominal pain should not be given analgesia, or at least enough analgesia, because that could mask symptoms. And if that's the case, particularly with inexperienced personnel, then even ultrasound and clinical assessment can be very difficult in them. So this is my list. It's very personal as to when I might consider using CT. There's a lot of overlap. That's just to say if you've got an abnormal body habitus, you might not have retroperitoneal pathology. Of course you can. And I just want to look at each of these categories in turn and illustrate it with some of the cases that have come either through my department or which have been referred to my department from other hospitals in Northern Ireland. So retroperitoneal pathology, first of all. And the big thing here is that oftentimes gas precludes you getting a decent examination of the retroperitoneal structures, particularly in older patients. So 2 cases here. These are children who had raised inflammatory markers, they had abdominal pain, and their pain was exacerbated with hip flexion. So here we can see a child, they had on the bone windows, they had sacral osteomyelitis. You can see the abscess here, and that certainly tracked further cephalad. This child had a retroperitoneal abscess, extended into the psoas muscle, was drained by one of my interventional colleagues, but sadly ended up, I'm afraid, getting a second CT because as a complication of his drainage, got a pseudo-abscess. He later had to go for conventional drainage there. Another case here of this time a sacroileitis, with a sacral osteomyelitis, again with abscess formation. This child, as you can see, got both CT and MR. Both of these were adolescent patients. So psoas abscess, it's lovely if I can diagnose it on ultrasound, but particularly in older children, I can't always manage it. This case here is a child who perhaps could have appeared in the trauma thing. This was one of my on-call cases. I had a panicked junior trainee ring me, telling me that a child had presented with frank macroscopic hematuria 2 days after falling downstairs. And in our institution, with a history of trauma, we tend to use CT. The CT was done, and he rang me up and said, that's not like any traumatic renal injury I've ever seen. So when I went in, the trauma was a major red herring. The child had abnormal bloods and raised inflammatory markers. And this child also, when questioning the parents, had a vague history of back pain going back 6 weeks. So unfortunately, because of the history of trauma, he got CT in the local. If we'd known about it, ultrasound would have been our choice investigation. But he does have xanthogranulomatous pyelonephritis with a big associated psoas abscess and calculi extruded from the kidney into that abscess, and also more pararenal inflammatory change and abscess. Sadly, that child, when he did have his nephrectomy after the inflammatory process had settled down, managed to develop Goodpasture's syndrome in his one remaining kidney. So he's now in grave difficulty as far as his renal function is concerned. And that's a case that's certainly within the last 12 months in our hospital. This I could have put in the abnormal body habitus. We all meet children who have bad neurodisability and they have a distorted body habitus due to that. And finding their abdominal organs is often very difficult, however long and hard you try, because the normal anatomic landmarks are just not there. And in this child, we'd certainly had a go with ultrasound first. We could see his kidneys, but we just weren't getting very good views of them. And we couldn't exclude the cause for his abdominal pain. And of course, because he has chronic neurodisability, the physical exam and the taking of a history, even in a teenage patient, is often much more difficult. When we ended up having to grit our teeth, we don't like doing this, but we did an unenhanced CT, a CTU exam, and we could see his renal calculus there. He had a smaller renal calculus also in his distal ureter, which we just could not see with ultrasound in him. Caveat here, CTU for stones, our adult colleagues do it a lot. I think you have to be very careful, high-dose exam, and of course stones might not be a one-off episode. So what we don't want is to encourage doing this in patients and to have repeat CT exams for a recurrent pathology. Complex post-op problems. I have to say that neither of these from my institution, they were referred in. We can see, as Simon would say, abdominal radiograph that tells us something is wrong. Both of these children were post-appendix. Again, as Simon would say, we put the ultrasound probe on because we can see this isn't gassy, and we saw lots of dilated loops, but when we saw a little bit of free fluid, but we couldn't find out. That really wasn't enough to tell us what was going on with this child. She was far too sick for that, and she wasn't settling with antibiotics. So unfortunately, in complex post-op problems, we had to resort to CT. And we could see her change of caliber in her bowel, diagnose her small bowel obstruction that we knew was there anyway, but what we were seeing with these interloop fluid collections, and that child ended up on the basis of the CT going back to the operating theatre to have those small collections drained to be washed out for her adhesive obstruction. This patient, I think, I have to confess, I think it's a shocking example of a CT exam. It's not from my hospital. This child had post-op appendix, complex neurodisability, and she had an ultrasound done by the radiologist, and they said there's a huge pelvic abscess there. And one would think that would have been the story. But unfortunately, the surgeons in that hospital were prepared to drain that, but not without a CT exam. And so, unfortunately, the CT was done, which showed an enormous pelvic abscess. And then they refused to drain it anyway. So if they are smaller, deep pelvic abscesses, I would say maybe sometimes we don't get the full definition with CT. I drained 200 mils of pus out of that under ultrasound guidance. So occasionally, pragmatism, or sometimes in non-pediatric hospital, this kind of scan gets done. What about inflammatory bowel disease? Again, same caveats as with the renal calculi here. This is obviously a chronic condition. These patients are going to be attenders at hospital lifelong. So what we don't want to do is to do CT or radiation-heavy examinations on them without thinking pretty hard about it. Occasionally, though, we do resort to it. So this patient here was having an acute flare-up. They had been managed medically by the surgical team, but they just weren't settling. Ultrasound had shown there were lots of dilated loops. You can still actually see the layers of the wall here, so that gave them hope. She was on steroids. See all the creeping fat here? She had a lot of nodes. They saw this free fluid in the pelvis, but what they couldn't work out is, was there anywhere where they could actively go and drain it? And the CT revealed that there were smaller interloop abscesses, which particularly in adolescent patients are sometimes difficult, if not impossible, to pick up on ultrasound. So that was scanned by my adult colleagues who look after some of our adolescent patients, and she was managed on the basis, and then her interloop abscesses were dealt with. This is another patient. They were scanned prone. I didn't just put my pictures in upside down. This is a patient who had a psoas abscess due to a fistula, known Crohn's disease patient. And you can see the pigtail catheter in situ here, which had virtually drained the psoas collection. But the patient's fistula the patient just didn't appear to be healing. This drain continued after weeks to still drain. And so what they wanted to do, and again, this is an adolescent patient, so my adult colleagues dealt with this, was they injected some water-soluble contrast medium through the indwelling pigtail and confirmed that there was still the fistula there. I have to say, as a pediatric radiologist, I may have opted just to do a fluoroscopic examination. But occasionally, again, pragmatism, these children are not necessarily managed by pediatric radiologists, and others may choose to do CT in that scenario. This patient here was, again, imaged outside, sent to my department as possible lymphoma. And this exam had been done because somebody had seen thickened bowel loops and decided this was lymphoma, and they'd done a staging CT. Absolutely, there are thickened and abnormal pelvic loops here, but there's an awful lot of inflammation and there's nodal change there. We see thickened and abnormal loops geographically distinct from there in the upper abdomen, and again more pelvic abnormal thickened edematous bowel loops. And we sent this back to our oncologist saying, well, good news for the patient, we don't think they've got lymphoma, but we think they've got inflammatory bowel disease, which was later proven as such. Certainly in all of these patients, I wouldn't advocate doing CT on a regular basis, but they were done in the acute scenario to deal with a particular problem, and so sometimes pragmatism is such that that might need to be done. We've all come across this. These are two of my recent patients. These three images joined together here are of a 10-year-old boy who weighs 90 kilograms. The first time he came up with vague abdominal pain and raised inflammatory markers, it took 2 radiographers to lift his fat apron to try and attempt to ultrasound him. We could see this little bit of free fluid, but definition other than that was no. And reluctantly, we had to say we were going to CT him. Of course, when you CT in that scenario, you also have to increase your imaging parameters. So it's not a low-dose CT because we needed the increased dose to actually get penetration to see. And here what we have is you can see his appendicolith There's his dilated appendix, and here are his complex loculated pelvic abscesses. So this was a case of perforated appendix, and even my experienced pediatric surgeons that I work with couldn't palpate deeply in this child's abdomen due to his girth, and I think that's a problem that we're all going to have to deal with. Certainly try ultrasound, but you may not get your answers. This was another big girl, another complex disability patient who had, we knew, a dislodged cecostomy tube, but my surgical colleagues wanted to know was there anything else going on in her abdomen. Likewise, we tried with ultrasound first, we'll always give it a go, but we couldn't rule out for certain any other problems, and we ended up having to do a CT. They wanted to know what they were dealing with to define the full anatomic and pathological extent of her disease before they were willing to do a laparotomy on such a high-risk patient. More abnormal body habitus. We can all see the abscess on the anterior abdominal wall. It was related to a PEG tube in another patient with complex neurological disease. One of the problems other than body habitus you find in these patients, she had a little bit of scoliosis, is they're oftentimes very, very gassy. There's a lot of air swallowing goes on with some of our neurological patients. And a radiograph like that, whilst I'll try and put the probe on at the flanks, you're onto a hiding to nothing oftentimes. So the same question was raised as with the dislodged cecostomy tube. Is this an isolated abnormality, or does this infective process extend deep and involve the intraperitoneum? The answer to that question was no, and I happily drained that abscess under ultrasound guidance in theatres, but the surgeons needed or wanted that reassurance that we couldn't give them due to all this gas on ultrasound. Similarly, this is another complex neurodisability patient. So these are kind of patients that we have a lot of in pediatric hospitals who presented with abdominal pain, raised inflammatory markers. The ultrasound of the upper abdomen, we got a glimpse and we could say, yes, there's nodal disease there in the bowel loops that we see some thick wall bowel loops, and we also see some ascites. So they had queried that this was an acute abdomen due to a tumour perforation. Pretty unusual, and it'd be very bad luck. But we went ahead and did the CT, and what we were able to tell them is, well, I'm sorry we've done the CT, but what we find is that this is a child with pancolitis instead. So it was unlucky, a child with neurodisability, to get pancolitis, but sometimes children do get dual pathology, and we have to be ready to deal with that. Simon mentioned immunocompromised patients. So here's a clatter of the patients that I see. A lot of them are oncology-based, either immunocompromised because of chemotherapy or organ or bone marrow transplantation. Of course, we have immunocompromised children who have immune deficits from birth, and we have children who are immune deficient because they have HIV or other infections, and they all come under this umbrella. What's really important is these children, it doesn't take very much for them to have quite major morbidity and mortality associated with acute abdomens. So Simon showed you a lovely example of ultrasound. This is quite an old example, but this is what typhlitis or neutropenic colitis looks like on CT. These are fungal abscesses. Again, you can see these on ultrasound, but occasionally what we're asked to do is to evaluate whether there's fungal lung parenchymal disease or whether there's fungal infection involving Waldeyer's ring, because depending on the severity of a disease will affect the treatment management and how long the children go on for it. We have this is graft versus host disease. Again, certainly ultrasound, if you can do it, would provide you with information. You may not need CT, but occasionally we do. You can see all the fluid and the bowel wall edema. This is a patient with rectal stumpitis, and they were querying post-transplant lymphoproliferative disorder in this patient who'd had recurrent flare-ups from their time of multi-organ transplant. And this is another patient. This is infective colitis in a patient. Again, some of these images are several years old now, and I think with more modern ultrasound that ultrasounding them would be of benefit, and may well give you the answer without having to resort to CT, particularly in younger children. And finally, and I'm going to skip the last few slides because my time is up, but just to mention CT-guided intervention here, we would certainly, and I've alluded to it earlier on, drain abscesses in children's in the acute abdomen with ultrasound when we can. Occasionally, though, particularly for deep-seated pelvic abscesses, CT guidance is necessary. And this is an example, you can see the appendiculus and the pelvic abscess here, of a deep-seated pelvic abscess. And one of my interventional colleagues drained this abscess through the sacrosciatic notch and put, it was a combined drainage with pigtail catheter placement in a child. And occasionally for that, you certainly can't use ultrasound. You need the CT-guided imaging to do that. I'm going to skip my problem solving and just go back and reiterate my learning objectives. So I hope that I've shown you some of the advantages of using CT, particularly for those of you who don't work in a dedicated paediatric institution, and shown you some of the clinical scenarios where CT is useful and where CT, we have used it when we've tried and failed with ultrasound. I think CT does have a place, but what I would stress again is that it's not a substitute for evaluating your patients clinically, and that we would generally try ultrasound, and if it's there, MR. And please, if you are going to CT, make sure your protocols are weight-based for the children and that you use as low a dose as possible. Thank you.